I hope that we can make this lecture in English. I think that in only English will not be enough. I don't know if we have participants from outside our Arabic countries. Do we have, Dr. Hussein?
Of course we have, yes.
All right, so this lecture will be English mainly, and I think that it will be more better for everyone to get use of this lecture. Again, hello everyone. I hope you are all fine. I hope that you and we all bypass this era of COVID-19, this era of diseases and this pandemic. I hope that we are all go through this era of COVID-19. Our lecture today will be bypassing like a POS, separated file bypass, when, why, and how to bypass. First of all, we have to know why the file breaks. We have two main causes of file separation. This sound of ringing, can we stop it? Can I close it or stop it? It's a little bit annoying for me.
Previously we tried, I'm sorry, but
all right,
we can't.
Okay, no problem, no problem. All right, okay. So we have two main causes of the file separation. First of all, cyclic fatigue, and second, the torsional stresses. Of course, we all know that these are the two main causes of file separation. Cyclic fatigue, mainly due to overuse, and this will happen more due to too much stresses, too much cyclic stresses beyond the cyclic fatigue limit of the file, and that's why it breaks. Simply, when we were all young, when we were kids, we can have this metal rod and try to bend it until it breaks. This is cyclic fatigue simply. But torsional stress and cyclic fatigue, by the way, as I said, occur mainly due to overuse. But the torsional stresses can happen with the files that you firstly use. Maybe the file is the first time to use and it can be broken due to torsional stresses, because simply torsional stresses is when the tip of the file is engaged inside the canal and the remaining shank, the remaining part of the file is still rotating. And this is simply torsional stresses. The exact mode of file separation, maybe we cannot know, it's unknown, maybe due to cyclic, maybe due to torsional, maybe both of them together. But you have to know previously why the file may break, because that will help you in your treating decision, in your treatment option decision. Maybe sometimes you will know that it will not be easy to bypass, it will not be easy to retrieve, and maybe you shift your treatment decision completely to surgery. That's why you should at least know why the file, if you are the one who did break the file, you have to know why the file was separated. Here we have a study by Sataban and his colleagues, and they noted that most of the files are broken in their studies. According to the results of their study, torsional stresses occurred in about 55.7%, and cyclic fatigue occurred in about 44.3%. And here he can say that the torsional stresses occur more, but we have a lot of factors. This is according to his study, but we have a lot of factors that control the cyclic fatigue and a lot of factors that control the torsional stresses. That's why it's a little bit different from one file to the other, from one case to the other. If you look at this picture, when we see this picture in any of the textbooks or even on the network, we just turn the page away because such pictures are not catchy for us. But if you look at this picture, from the figure number 2, you can notice that these files are broken or were broken due to cyclic fatigue. You can see that the fluids are regular and the fracture site is a little bit smooth or regular. But if you look in contrary to the other picture on the left, you can see that the floats are open. The flutes are open and it's irregular, and even the fracture site is not smooth, not regular as the one on the right picture. So most probably, figure number 1, the files were broken due to torsional fatigue because the flutes were open, torsional stress is sorry, and figure number 2, because the flutes are a little bit regular and not open, so it may be more probably broken due to cyclic fatigue. We have a lot of factors affecting cyclic fatigue. We have a lot of factors affecting torsional stresses, but you have to know that most probably the factors affecting cyclic fatigue is indeed the canal curvature. And nowadays, we don't take the angle of curvature as the only factor as the right factor to detect the difficulty of the case, but we now take the radius of curvature, not only the angle of curvature. And it's not our topic today to talk about that, but we have to mention, and indeed the instrument size also, and this factor plays a big role in the torsional stresses also, because when the file is a little bit bigger in size, it will decrease the probability of the file to be broken due to torsional stresses. Simply, as we say it in Arabic, لو الفايل محمل, if the size of the file is big, it will withstand more the torsional stresses. All right, okay. Now let's move to the other part of our lecture, the factors affecting the success or failure of bypass or even also retrieval, because we have to mention both of treatment options. When we have a broken file inside the case, inside the tooth, we have 4 treating options. First is bypass, second is retrieval, third is to leave the file and obturate to the level of the broken file, which we call in Arabic irdem عليه, and this option I don't like to be the only option in our clinics. Yes, we sometimes do it, but in very, very, very certain conditions. And the fourth is to go retrograde from outside to do periapical surgery. These 4 treatment options is considered if you have the right tools, the right armamentarium, you have a microscope, you have a good magnification and illumination, and you have good protocols to follow. If you have all these pre-required armamentarium and knowledge, so we have these 4 treatment options. These factors will affect your decision to choose which factor of them, which treatment option of them, and also will affect your bypassing or retrieval, as we will see. We have factors related to the tooth, we have factors related to the separated file itself, we have factors related to the operator, and we have factors related to the patient. First of all, factors related to the tooth, type of tooth. Of course, if you are working on an anterior tooth, it will not be difficult as in premolar area, and also it will not be difficult as in molar area. Also, the cross-sectional shape and diameter of the root canal that we are working upon. If you are working on a mesiolingual or a mesiobuccal canal in the lower first molar, it will not be easy as if you are working on the distal canal of the same tooth. And indeed, also, this diameter of the root canal will control our decision, will judge our decision to do bypassing or retrieving, because sometimes if we decide to retrieve the file, we can remove a lot of tooth structure, and that will indeed lead to root weakening, even the tooth will be fractured easily after that. Also, an important factor is the position of the fragment in relation to the canal curvature. And here we have to stop for a little time. Once upon a time, we decided to divide the separated file cases into, all right. We did divide the separated file cases into separated file in the coronal third, separated file in the middle third, separated file in the apical 1/3. From this lecture, from now on, we are going to divide our separated file cases into separated file before the curve and separated file beyond the curve. According to the position of the broken file to the canal curvature, we will divide it, or we will divide them into files broken before the curve and files broken beyond the curve. And according to that, we will have two different treatment options. Okay, now the other factors related to the tooth are the file canal wall interface, the gap between the file and the wall. This gap, we will depend on this gap to do bypass or even to do retrieval. Okay. Okay, these were the factors related to the tooth that we will work upon. Now, what about the factors that related to the broken file or the separated file that we have inside the tooth? First of all, the time. If you have a broken file, hand file, it will not be the same indeed as rotary file. If we have all the factors, the same factors, if we make all the factors are the same and we are trying to compare between a hand file and a rotary file, if we have only the variable factor is the taper, so dealing with hand files will be much more easier in bypassing indeed than dealing with rotary files. Also the design and the cross section. Try to imagine if you are trying to bypass a K file and trying to bypass an H file. If you are trying to bypass a K file, to retrieve a K and to retrieve an H file. Indeed, it will be completely different. And also this part of cross section, we have to know that historically we have a lot of cross sections for the files. And until now, we have too much cross sectional, too much geometry for the rotary files even, but most probably nowadays we have this kind of heat-treated files, rotary files with triangular cross section. We don't have these landed files as the blue file once upon a time, a long time ago. We have this kind of landed file like the blue file. We don't have nowadays this file. Indeed, it's still present in some clinics, in some hospitals, especially in Saudi Arabia, but we are lucky nowadays that we have this heat-treated file with the triangular cross-section. This makes them a little bit more easier to bypass. And also the length of the separated file. This factor affects a lot our decision in bypassing or even in retrieval. Because if we have a separated file more than 3 millimeters, in bypassing, try not to bypass it in one shot. Try to bypass a little bit, the 2-3 millimeters first, and then the other millimeters. The same in retrieval. If we have a broken file or a separated file, more than 4 or 5 millimeters in length, we will choose another way of retrieval. It will not be only ultrasonic is enough. That's why we go to wire loop technique or whatever the holding technique that we may take the file out with. It's generally believed that the nickel titanium are more difficult to do or to deal with than the stainless steel. even in retrieval or even in bypassing. As we mentioned, we have some factors, they are threaded because of the rotation motion. Also in retrieval, we have this kind of secondary fracture because the nickel titanium respond differently to ultrasonic energy than stainless steel files because they are weak. And also the other or the third factor is that when they break the ligand, the outer wall. And by the way, that will help us to know that we are going to try to search for the gap that we mentioned before, that will be between the file and the wall. We have to search for it in the inner, because the file, if it's rotary file, nickel titanium file, it will lie against the outer wall. Some factors, operator to yourself, you have to be patient, you have to have a good protocol, as we always say in the style Italiano, feasible, teachable, and repeatable protocol. You have to have this kind of knowledge, training, familiar with the techniques and instruments, preservation or perseverance indeed, and creativity. But please, creativity sometimes kills. Try to be creative. I'm not against creativity, but to a limit, because sometimes creativity kills. You can see this elephant standing on the bowl. This elephant should be you, me, or whoever will deal with separated file cases, because you have to have this balance inside your mind between removing the harm or dealing with the harm. Either you will remove, bypass, or and also you have to not to sacrifice a lot of tooth tissues, because sometimes we choose retrieval. All right, this is good, and we have to say something. As you can remove the file, it will be better. You have to know that logically. As long as you can remove the harm, as long as you can, it will be better for cleaning, for shaping, for obturation. But sometimes when you do this, you sacrifice a lot of tooth structure. That's why not to have this only option of retrieval. No, you have to have this balance in your mind between removing the harm and to save virgin dentin. Say virgin dentin, or in Arabic it's al-ag al-bat. You don't have to remove a lot of virgin dentin because you will weaken the tooth. Now, the factors relate to the patient, the extent of limitation in accessing the tooth, time constraint, and anxiety level. These explain and describe everything to your patient, but for me, the most important factor related is if he honestly knows that it's not easy. He has to respect that, respect your treatment option, and he has or she has to put her trust or his trust on you. Are the only one responsible for the case. So when the patient comes to your clinic and you decide a treatment decision, you have to be completely sure that this is the right decision you take. If you bypass or if you retrieve or whatever the treatment options that you will choose, ensure that this is the right decision. And also the patient should pay for your work. By the way, in my clinic, the fees for bypass are the same for the fees of retrieval. Simply, sometimes bypassing take more time, more instrument, and your time is money. So you have to know, or you have to take the right amount of money that you should. And by the way, in our Arabic countries, I'm sure that whatever the amount or the fees that we will take, it's not enough for the work that we do. Anyhow, now let's move to the catchy part of our lecture, the broken or file bypass. When to bypass? From the factors that we mentioned, simply when it's more conservative. Look at this case, we have a broken file beyond the curve. we have lack of visibility. Even if you have a microscope, you have to remove a lot of dent in here to reach the file. Then you have lack of knowledge or instruments to retrieve. So this is simply when, or the answer to the question, when to. How to bypass. I will not tell you how to bypass. First, you have to know that prevention is better than cure. You have to know that to avoid bypassing, don't break a file from the origin. Prevention is better than cure. But we are all sticking to broken file cases. That's why we have to know how to bypass. The other question, what is bypass? If we look at the word bypass on the dictionary or at Wikipedia or in Google, we will see that the word bypass is related to the cardiology department. This is coronary artery bypass. When the coronary artery has something blockage and blocked it to read the blood, they do this kind of coronary artery bypass so the oxygen-enriched blood can supply the muscles of the heart again. Word bypass is to go beyond or around something. In dentistry, we are all suspected of cases. Either we break or even refer to our clinics broken. So we have to know how to deal with separated file cases, that the right decision, the right treatment option is bypass. So now we know when to bypass, simply when it's more conservative. We have a broken file beyond the curve, and the right way is to be conservative, is to bypass. And this is now the bypassing protocol. We have to have a protocol feasible, teachable, and repeatable. And by the way, this protocol I shared in a lot of countries. But if you can, by using this protocol, by 7 or 8 cases out of 10, 70, 80% of cases, that will be very, very, very good for me, for my protocol, and for everything. So let's talk about the protocol. First of all, we have 3 main preparatory steps. Sorry. First one is patient management and communication. You have to describe everything. You have to explain everything to your patient. Try to have an early appointment. Try to make him relaxed. And as long as you can have early appointment, you will be relaxed. He will be relaxed, and everything is gonna be all right, inshallah. Second step is to make a analysis. Indeed, if you have a combined CT, it will help you to know a lot of things. Even if you have only 2 dimensions, you can know from the X-ray, the position of the side, the direction of the curvature, the length of the broken or the separated file, and you can also know the inner curve, outer curve. You can know the diameter of the root canal. You can know a lot of information from the preoperative X-ray that you were starting. Number 3 is to have a straight open file. Sometimes we do it coronal clearing by the orifice openers. Historically, we used piezo-reamers, we used large edge files, but nowadays we have heat-treated orifice openers, so why not to use? It will be conservative and the access will be a little bit centralized. And for the access cavity itself, I'm not against new access cavities. Let's tell them modern access cavities, Ninja, Truss, ever the name of the access cavity, but of the conservative traditional access cavity. All right, now dealing with the file. We have 2 steps. This is the most important part. To focus on this part. First, the initial negotiation, or to gain a catch, or to go to the space, the gap that we have between the file and the canal wall, is completing our bypassing. The first step is the most important step, and also the second one, but the first one is the door, the opening. If it's right, you will complete your bypassing on the right way. So in this step, we need a specific file with a specific motion, with a specific irrigant to do this in the right way. The file that I will use here will be dfinder. I don't like C+ files in this step because it's a little bit more dangerous or more risky. So in this step, I have the tip of the dfinder is non-cutting, to be used in this step. A picking motion, gentle in and out strokes, and I will show you all that in the next slides. It's very, very small, short strokes, in and out strokes until you have a catch. Once you have a catch, go and make sure that you are in the right way, and then after that, pass it with manual files or hand 10, 15, 20, or sometimes even to watch winding motion until complete your bypassing, and then to rotary files. The irrigation that we are going to do will be sodium hypochlorite. EDTA solution at all on gaining a catch or even during bypassing, because EDTA solution is a little more risky to be used, especially with C+ sort of stiff files with active cutting tip that may lead to perforation sometimes or atherogenic errors. Now look, this is a little bit summarization of all the protocol of bypass. First with the dfinder to gain a catch, and then with K 15, 20, and sometimes to 25 the rotary files. Any kind of heat-treated rotary files you can use for making a good glide path up to 25. Hand file indeed. Now let's look at this video. Part of, we have here a model is already open, the axis is already open, and we have a broken file inside it. Try always to work on a wet condition, never ever to try to work on a dry condition. With sodium hypochlorite, here is the dfinder number 10. Very gentle in strokes, in and out picking motion. We have a catch. Once you have a catch, out and bring your K file number 10 with watch winding motion. Very important, because I know that our watch winding is not, the watch winding motion is very gently, very, very gently, back and forth, pressure, that your file is advancing inside the. This is K file number. Very gentle watch winding motion until you feel that it's not advancing more inside the canal. Go out, do some irrigation. Now you can see we start accelerated file. Yes, but we cannot reach. It's not easy to push more or to go or advance inside the canal. Do not push your file. Do any kind of force just with watch winding motion until you can. Now, if you can see in this model, yes, I bypass the file, but we have second curve here. We have secondary curve that we cannot take with K file number 10. Maybe I will have some risk of making an artificial apex or some sort of iatrogenic errors here. So I decided to increase the bypassing space here with K file number 15. If I increase the bypassing space here with K file number 15, it will be more easy for me to go back to K file number 10 again. And in this case, I will reach the full working length in an easier way. Now you can see with some kind or sort of watch winding motion, I can completely bypass the broken file. Indeed, I will not reach the full working length, but my work here was only to bypass a little bit the broken file. Here with the K file number 10 again, I can advance more inside the canal, indeed, and you can see with very, very gentle apical pressure, I can reach the full working length. Yes, we are now reaching the full working length. We can take our length. I will have 10-15 minutes to questions, don't worry, because I can see some of you raising their hands. I will answer all these questions, I hope. Now with K file number 15, after we can move from K file number 10 to 15 or from whatever is the size to the next one, after the file is completely loose inside the canal. When K file number 10 is completely loose inside the canal, I can go to K file number 15. You can see here K file number 15 can bypass, can advance inside the canal, but cannot be easily taken the second curve. So I will go again to the bigger size, K file number 20, to increase a little bit the bypassing space. You can see that K file number 20 is a little bit engaged inside the canal. So I will go back, irrigate, clean the fluids, and maybe I will go or come back again with K file number 15 to try that I can reach the full working length or not yet. Yes, after irrigation, I put my K file number 15 again, and yes, it can be easily reaching the full working length. That's why I always say that bypassing is a game of hand files or a game of manual files or a manual file game. With K file number 20 again, I try to advance inside the canal, but I cannot reach the full working length yet. So I can go out, irrigate, and I can go to 25 or even to 15. 15 was not loose inside the canal yet. I think that now it will be very loose inside the canal, yes, and it can reach the full working length very easily. Then I will go to K file number 20 again. Listen to that. Easy come, easy go. Easy come, easy go. Bypass is not easy come. So please try not to make it easy go. Bypassing is a little bit stressful. treatment option, we choose sometimes to be conservative. So we have to be very, very gentle. Now with K file number 25, I'm trying to, again, increase the bypassing space a little bit, so K file number 20 can reach the full working length. When K file number 20 can reach the full working length, and indeed, if we can have 25 also reaching the full working length, we will have this kind of glide path, big glide path for the rotary file to be used. Here is 25 K file, cannot reach indeed the full working length in one shot. And you can see the debris accumulating in the apical part, apically or beyond the broken file. Here is K file number 20 again. Yes, it can reach the full working length now. So I will go back to K file number 25. Once we have the K file number 25 up to the working length, you can use the rotary files. But here, I do not recommend to go to 2504 immediately. No. Try to go first to 2004 rotary file and then to 2504 to decrease a little bit the probability of file separation. You can see the amount of debris here due to the shaping. That's why I go now to the rotary files to increase the diameters, the taper a little bit, so I can irrigate. And you can use indeed the regime files. They are very good and very flexible and very safe to be used in bypassing. But as I always say, if you are going to use any kind of files, any kind of heat treated files, or even hand files, they must be all new. Do not take a file ميت إكلينيكيا عندك في العيادة بقاله 60 سنة. The file is completely in a bad case and you can, and you use it again. No, do not do this. Please, if you are going to bypass with hand files or even rotary files, try to use them all new. We have some trick you can use also in bypassing. Not this video, yes, this one. After indeed making a good axis and all the preparatory phases and make a formal axis or straight line axis with the broken file, you can see now that we are going to use the D finder in a reciprocating handpiece. And this trick is very useful in bypassing. The D finders on the reciprocating handpiece can do magic in your hands, honestly. The D finders are a great files that are already designed to work on this kind of port winding motion. With the right reciprocating handpiece, you can have magic in your clinic. You can see now the D finder even bypassing the broken file. That's why I'm telling you that this trick is really great. And as I told you, you can use regime rotary files because they are very flexible and you can use them in bypassing. Now to some cases, and then we will have the time for the questions. Here we have a broken file beyond the curve. That's why in a very thin, long root with a periapical bathosis, that's why I decided to bypass the broken file. And yes, we were able to bypass it. And here is the obturation, and here is with the shaft, and here is with the other mesial shaft. And we have this kind of lateral fillings. We have this kind of 3D obturation. I hope that this is 3D obturation. Another case was a broken file beyond the curve in the mesolingual canal of a lower first molar. Also, we were here very lucky that the two canals are opening together. That's why bypassing or do shaping to the main canal or the other canal will make it easier to bypass the canal or the mesolingual canal, the canal with a broken file. And indeed will make also obturation easier. Some people, some schools says if you have this kind of a broken file in one of two canals that are opening together in the same portal of exit, you can shape and obturate the main canal and do only shape to the broken file and obturate to the level of the broken file. But why not to give it a chance? Why not to give it a try to bypass it? Anyhow, this first lower molar was for a colleague. He was a dentist also, and he came to my clinic seeking for root canal treatment for this tooth. And I told him that it's a little bit in a disastrous condition. We have too much distraction. We don't have too much saved tooth structure, but he wanted to save it. And he said that he is the one responsible for that. And I told him, okay, no problem. Let's give it a chance. And here you can see that he has a broken nerve approach or a barbed approach. I don't know why his colleague used nerve approach in a necrotic case, but anyhow, we have a nerve approach broken inside the mesolingual canal of lower first molar. It was not difficult at all to bypass nerve approach, but the problem is not to push the nerve approach or the barbed approach more beyond the apex. And in these cases, if you are one of those apical patency lovers, as me, because I'm one I'm a big fan of one of the lovers of apical patency, try not to make apical patency here more than with K file number 8, for example. Try not to make it as we always do with K file number 10 to check the patency in such cases to avoid pushing the file more beyond the apex. And here you can see the mesocone X-ray and the obturation post-operative. And this 1 year follow-up was about 3 years back follow-up, 3 years back. And we have up till now a 4-year follow-up and everything's fine, everything's great, touching wood, thanks God. Here we have also broken file in the distal canal of a lower isolated third molar. And I am the one who did break this file because we all do break files. And when I did break this file, I was not so happy. I was a little bit upset, but then I thanked God because the file that I did break here, he guided me to the right portal of exits, the right direction. So sometimes when we have bad news, it may have good news on it. Another case with 5 broken small hand files and the mesial root of a lower first molar, and I bypassed all of them. And here is the master cone. We were very lucky that we have only one portal of exit in this mesial root. And here you can see the great magic of creativity for Allah subhanahu wa ta'ala, for the God. You can see the mesial root complexity of this molar, and you can see also how we filled it. And by the way, the obturation technique I used here was cold lateral condensation with bioceramic sealer. Yes. And here is the follow-up. Here is the follow-up after 1 year and a half. And this 1 year and a half follow-up was about 2 or 2.5 years ago. And everything is fine up till now, touching wood. Here in this case, I have to discuss something. If you can look at this case, we have a broken file here. And from the 2-dimensional X-ray, as any idiot, I decided to retrieve. I look at the 2-dimensional X-ray and I told the patient, I will retrieve the file. It was in the mesiobuccal canal. Then, after removing the gataperca from the mesolingual and the mesiobuccal canal, I cannot see the file. Under the microscope, yes, I cannot see the file because we have 3rd dimension. We have curvature in the 3rd dimension that I cannot see or detect from 2-dimensional X-ray. So I decided immediately to shift my treatment decision from retrieving to bypassing. And I told the patient that, and I told her that I'm completely responsible for that, and this is the most conservative for you. And she said, I'm all yours, doctor. You decide, you do the right thing. So immediately I shifted my treatment decision from retrieval to bypassing, and it was easy. I did bypass it in 10 minutes. And while I'm doing the master cone, I shaped to up to 3504. And once I put the master cone, once I was taking the master cone out, the file was little bit loose and it go deeper inside the canal, but it didn't came out from the canal because my apical patency was good and I didn't make too much violation for the apex. In such cases, what do you think is better? To leave it? Yes, we did good shaping. Yes, we did good irrigation, but we will not have a good obturation or apical seal. So in such cases, I bypass it again and it will be easy. But here I will not bypass to the same size and diameter as before, because in this area, very thin area, I will not bypass it again with 3504. No, I will just bypass it up to 2502 to put my master apical cone, which will be 2502 with bioceramic sealer to have, or to try to have a good apical seal. Another case, long broken file, I decided to bypass, and after did bypass, you can see here this angry lady. The white arrow is pointing at her. I don't know why she was angry. Anyhow, the patient went out and she came after that. While I do my irrigation protocol, while I do put my ADTA solution and activate it a little bit, the file came out. Now I know why this lady was angry. When the file came out and I did obturate the case, here you can see there is no angry lady. Thank you. When I saw this angry lady on the picture of the sensor, I thought that I have some kind of ghosts in my clinic. Anyhow, this is my profile account. You can contact me anytime. You can ask me anytime and anything. And thank you. I hope that you did like the lecture, and I think it will be also recorded the same, because I think that a lot have questions. If someone have a question, if you want me to answer any question, I am all open.
Okay, thank you very much. It's very clinical, and this is what we really want, because we want our participants, our newly graduate dentists, to see for their with their own eyes that bypassing really works. You know, I really totally agree with you that with the rotary era, we've got certain problems, and one of them is the separation. I totally agree with you about prevention better than treating. Treating prevention is better than treating bypass. I had a lecture, I think around about a couple of years ago, regarding this, and I told them that we really think about how to bypass and what type of instruments, and we didn't even talk about how can we prevent it. So it's very nice. About the questions, if we've got a ledge just near to the bypass area, how would you manage this this ledge? Do you pre-curve the instrument, and you know, what's your management?
If we, for an example, we have a long separated file and we try to bypass about 2-3 millimeters, and then the flutes of the file take us to the outer curve and we make a ledge on the outer curve, because that happens a lot. If you have such a thing, you can just a little bit the bypassing space in the coronal part to this ledge a little bit, try to widen it, and then after that you will pre-curve your D-finder, because here in such a ledge you have to renegotiate the main pathway of the canal. And in this step, I will need a little bit stiffer file like the D-finder, and I will pre-curve the D-finder. I try to bypass also this kind of ledge, because in this situation, you will have a broken file and you will have a ledge together.
Mm-hmm. In cases when you've got a separated instrument, you start to negotiate the separated instruments to the inside of the curve or the outside of the curve?
As I said, from the inner curve, it will be much more better. But sometimes you cannot guarantee that you will have the catch in the inner curve. So if you have the catch in the outer curve, you have to be more cautious. You have to be more careful in bypassing.
I totally agree with you. I remember this was a topic I talked with Professor Tarucci about.
Yeah.
That was in India, and he stated that it would be much better to bypass or even remove an instrument when you negotiate from the inside, because when you negotiate from the inside, you've got a back of dentine for the separated instrument to go on it. In this case, you will not have a second fractured instrument.
Yes.
So I thank you very much for this. And I think, can I? Of course, we've got these safe-sided files. I think Fanta has got one of them. Yeah, I think this would be some rather promising separation.
Yeah, very, very easy to be bypassing. By the way, when I was in Poland last year, one of the participants told me that I use flat side design from Fanta because when I break it, I can easily bypass it.
Really, when I saw it, I found that this is something very nice. And one of my PhD students is working on modifying the rotary instruments in Iraq here. And we've got this in our mind, how things are going to make things easier for us with the flat-sided.
Yes, by the way, I'm sorry, Dr. Hussein, I have to add something. Indeed, bypassing flat side design will be very, very easy, but never ever to use flat side design in bypassing. If you have a broken file and you decide to bypass with a rotary file, do not use flat side because it will be very easy to be broken and to flip جنب أخوه.
The last question, if you may, after gaining access through the separated instrument, what type of agitation of irrigation do you use? Whether sonic, ultrasonic, what?
Yes, we can use sodium hypochlorite with ultrasonic. I always prefer ultrasonic. Sonics are also good, but here for me enough to use sonics because I am afraid a little bit to touch the file or to make some digging with the ultrasonic around it. If you are going to make it passive inside the canal, it will be fine, but try not to dig around the file with the ultrasonic, not to avoid making a false pathway.
Okay, of course, I think that's it. I think there's only the last question. If a broken file in the last 2 millimeters epically in the lower 7 mesial-buccal canal, when we have confluent canals with mesio-lingual, how you can deal with it? I mean, maybe he's saying that when we've got confluent, do you keep the separated instrument? I think you talked about it very nicely.
Yes, I have one case, and I said about it, and I bypassed it and obturated the main canal, and also I put the master cone in the same the other canal with the broken file. I bypassed it.
Mm-hmm. So, so you're much of a bypasser more than trying to retrieve?
No, not at all.
Uh-huh.
I always do retrieval more than bypass in my clinic.
Mm-hmm.
If I have, for example, 10 cases of separated files in my clinic, I retrieve about 8 or 9, honestly.
Okay.
It's according to the case.
According to the case.
But because of bypassing glycopos, this name was only related to my name. That's why.
So this is really very important for our colleagues to understand that we have to study the case very well and see if the case can be removed by our traditional ways, or if not, we can do a bypass. But of course, in cases of bypass or retrieval, we really need magnification. We really need to widen up our access so that we can see as much as possible epically to negotiate our separated instruments. Of course احنا بالنهاية نشكرك شكرا جزيلا. طبعا شكرا جزيلا لموافقة حضرتك انه نسجل المحاضرة ونخليها بالchannel Simplifying Endodontics with حسين الهويزي اليوتيوب channels. احنا راح ننزل اللينك ان شاء الله. طبعا مشكور جدا دكتور وليد for this gesture لانه مو كل الزملاء والزميلات قدروا يدخلون. تعرف رمضان يمكن واحد يكون مكسل شويه زين، فنعطيهم الاوبشنز انه هو يشوفون المحاضره. خاصه it's a very clinical lecture. On behalf of the Iraqi Endodontic Society, we're going to send you a certificate of participation thankfully in participating in these series of webinars, and really it was a very good lecture, and we really thank you for your participation.
Thank you.
And we hope that we see you later in other events, whether virtual or in person.
Inshallah. It was my honor. Thank you, Dr. Laf.
شكرا جزيلا. مع السلامة. وعليكم السلام ورحمة الله.